Good morning, everyone. As you know, UN Mehta Institute of Cardiology and Research Center is organizing a weekly academic session for continuous cardiac education. This week's presentation would be on off-pump coronary artery bypass grafting, which will be presented by Dr. RAJESH THOSANI sir, who is Associate Professor in Department of Cardiac Anesthesia at UNMICRC. He has 22 years of teaching experience.
Hello, good evening, good morning, good night, depend upon your time zone. I am Dr. Rajesh here, and today's my topic is anesthesia for off-pump coronary arterial bypass grafting. So let me see from definition what is that. Off-pump means you are not using cardiopulmonary bypass. Means the revascularization of myocardium is either with arterial graft or venous graft without using CPB. There is no need of cardiac arrest, and the heart is grafting when it's beating. There are various techniques for the off-pump surgery. One is a midline sternotomy, that is a conventional, and another is a mix, that is a minimal invasive coronary surgery. But today we are talking only about this beating heart CABG from conventional route. Now we see what is the coronary artery disease. It is a leading cause of the death globally in geriatric age group. During 2019, at the era of COVID, the 32% death was happened because of the coronary artery disease amongst all global deaths. So it's nearly 4 to 5 times high than the routine. After the COVID-19, the younger population affected more for the coronary because that may be a hypercoagulable stage, lack of exercise, lazy life, then some stress, hypertension, and COVID of course itself. There are so many other hidden factors that we are working out, because nowadays we are doing a CABG of patient between 30 to 40 years after the positive history of COVID-19. So it's a warning sign for young age to prevent the coronary artery disease. Let me see what's the history, how it's off pump is started. So it started in 50 to 60 years back. In 1952, the first CABG done by Gibbon without using CPB. Off pump CABG in 1961 and 1964 by the Colsaw. He has grafted Lima to LAD only. And in 1967, Favalaro did the reverse saphenous graft. In 1968, the Green did a Lima to coronary artery surgery. So this is a brief history that since 60 years there is so much revolution take place, and today the scenario is different. Most of the surgeons and paramedical doctors, everybody is acquainted with the beating heart coronary artery surgery. So if it is too much popular in 60 years, there has to be some advantage. Let me see what that advantage. First of all, during pump surgery, there is a high chances of systemic inflammatory response system. What is that? That is the inflammation happening during the pump when there is a non-pulsatile flow. There is high chances of myocardial ischemia, hypothermia, and using of extracorporeal circuit. This all factor leads to systemic inflammatory response system. So once you using the pump, it will be prevented. Again also, in a pump, there is a prevention of the coagulopathy because you are avoiding a pump. Because of the partial heparinization, you have a very less blood loss. So again, it's a very helpful to prevent the transfusion related hazards and all. In pump surgery, there is a disruption of the coagulation system and hemodilution. These all factors leads to bleeding problem and multiple transfusion that may increase the hospital ICU stay as well as some of the complication related with the blood transfusion. Now another is a most common is a neurological dysfunction. So it's mostly happen because of the embolization, hypoperfusion, hyperthermia and inflammation. These all complication can happen when you are doing a pump surgery. Again, this neurological dysfunction is divided in two types. Type 1, that is a stroke, hypoxic encephalopathy, stupor and coma. If patient is having a diabetes, the atherosclerosis of the proximal aorta and pre-existing cerebral blood flow impairment. These all group of patients are more prone for the type 1 neurological dysfunction. Type 2, there is an intellectual dysfunction, memory loss, confusion and agitation due to small microemboli and inadequate perfusion. So once you are avoiding a pump, you can avoid the neurological dysfunction. The incidence of neurological dysfunction is 1% in off-pump CABG, while compared to on pump it is a 9%. So there is a 900 times more chance of neurological dysfunction once you are using a pump. Let me see of the myocardium. There is a less myocardial injury in case of off-pump CABG. Pulmonary dysfunction mostly happen because of the alveolar atelectasis, inflammation, increasing the shunting and volume infusion. So these all complications we can avoid by not using a pump. There are less chances of renal impairment if patient is done without bypass. If you bypass the pump, you can reduce the renal complication. If anyone has advantage, of course, it also has its disadvantage. What are they? You must need a high skill and experience to perform a beating heart surgery. Second is you may compromise a grafting due to hemodynamic instability in some of the region like OM and high ramus. You have to use octopus. That may be chances of device induced myocardial damage because of the negative pressure suction effect in an octopus. Out of which, what is our goal of anesthesia? The goal is the safe anesthesia with maximum cardiac protection and the stability. The maintenance of the hemodynamics by physical or pharmacological method. The fast track recovery and early ambulation and adequate post-op analgesia. This is our goal. So how we can achieve this goal? So let me see one by one. Now we start with the anesthesia management. Again, it's divided in three parts. One is a pre-operative assessment, one is a intraoperative management, and third is a post-operative care. In pre-operative, you have to check a pre-anesthetic assessment or pre-anesthetic checkup, preparation of the patients according to the pathology, like patient come with comorbidity like diabetes, hypertension, thyroid, so many other factors you have to taken care for that. Optimization with the medical management and prepare the patient so that you can plan for the surgery. You have to go with some basic investigation as well as special investigation like coronary angiogram and echocardiography. This is a brief. Let me talk once everything in detail from the next slide onwards. Intraoperatively, it's very important for the cannulation, induction of anesthesia, hemodynamic maintenance during the grafting, and management of any emergency complication at the time of grafting. So this is our various part of assessment we can plan out during the surgery. In post-operative, we have to maintain proper analgesia. Our aim should be early ambulation and reduce the ICU stay so that the patient can go home very easily. First we look about pre-operative management. What is that? You have to check the patient thoroughly. You have to check the patient pre-operative assessment, what anesthesia assessment you are doing routinely, as well as you have to check for the airway assessment if patient is having a difficult intubation, borderline difficult intubation. So you have to prepare accordingly for the boogie video assisted laryngoscopy or with the fiber optic bronchoscopy. The vein is very important because nothing is possible or anesthesia is not possible without vein. So you have to select a good vein because it is an extra major surgery. You need induction as well as fluid management and other drugs to be given through the IV. Sometimes the patient admitted in the hospital since long and the most of the vein is utilized because of the sampling as well as some of the drugs. There are high chances of thrombophlebitis. So you need a large bore vein at the time of operation. So assessment of the vein part is very important. Second one is the arterial cannulation. So most of the time, majority of the times we are locating a radial artery. So Allen stress is must. It should be negative. So and before taking any radial line, you must be sure about the collateral circulation with radial and ulnar. Blood investigation, of course, you have to check all the basic investigations and special cardiac investigation. What we are planning for the surgery is angiography, echocardiography, Carotid and renal Doppler is very important because patient may come with other vital organ atherosclerosis. During the surgery, high level of blood pressure fluctuation may hamper the cerebral as well as renal flow, and patient may end up in post-operative complication. Another is a systemic illness and comorbidity like diabetes, mellitus, hypertension, thyroid, acid peptic disease. That is very vital. Most of the time we are missing LPD because you are heparinize the patient. That may be chances of conceal or third space loss intraoperative period if patient have gastric ulcer and continuously you are in trouble. In such kind of patient, once you put a Ralph's tube, always check for the aspiration whether it's a blood stain, normal, or it's a bile or something. So it will give assessment once you have to miss, but be careful, always ask the history of the acid peptic disease. Again, pre-medication will come before the posting of the surgery. You may give anxiolytic, H2 blockers, or any other medication which patient is taking for that systemic disease. Medical management, you have to assess the what current medication patient is taking. If patient is taking beta blocker, you can continue during operative periods. Antiplatelet, it has to be stopped at least 3 days before the surgery. If patient is having a left main coronary artery, you can switch over to the heparin. AC inhibitor, calcium channel blocker should be stopped 1 day before the surgery. Low molecular weight heparin, you can stop 12 hours before the surgery. Unfractionated heparin, 6 hours prior to surgery you have to stop. Thyroid medication you can continue for the surgery, because if you don't give, there may be chances of the hypometabolism of the drugs and patient may have delay recovery in the ICU. Again, pre-medication, one of the most important things for the anesthetics. Most of the time we are used to with the intramuscular pre-medication, but in cardiac patient we are not using because we are heparinize the patient. Some patient may have fear of the needles, and there are high chances of some of the trauma like bleeding or hematoma formation at the site of injection. So once you are securing IV lines, always use low dose of benzodiazepines, anticholinergic, or very small dose of opioids. Just patient relax and calm, and you can shift the patient in intraoperative period. We are routinely using the proton pump inhibitor like pantoprazole, antiemetic like AMSAT, and we are giving intravenously before taking the patient in the operation theater. So we have preparation area where we are taking our lines under local anesthesia, and we are giving some of the drugs, little anxiolytic, and shifting the patient in the operation theater. The most important is close monitoring is required. So your preparation area must be equipped with the basic minimum monitoring system, so that you can find out or detect the early complication. And once you are giving benzodiazepines or some of the drug, you have to be more careful for the respiratory depression, because patient may come with COPD, old age patient, they are very much prone for the respiratory depression. The second part is intraoperative management. In preparation area, we are, as per I told, we are taking a large bore male vein and arterial line according to the plan of the surgery under local anesthesia. Arterial line is very important. The dominant hand should be cannulated with the radial artery, because sometimes surgeon may use radial artery as a conduit. So you have to spare the radial artery for them, and of course should not take vein on the side where they are taking a conduit. The monitoring is a ECG, IVP leads. You can take arterial line, CVP line or PA line. You can choose according to the condition of the patient. If patient is having a good ejection fraction, you can use 3 lumen or 4 lumen central venous line. Sick patient like less than 30%, you can use PA catheter or continuous cardiac output catheter, depending upon your setups and your availability. Oxygen saturation and temperature monitoring is very vital. The endotracheal intubation, it has to be very smooth, safe, and prevent with sympathetic stimulation. So it's very important. You should not have tachycardia and hypertension, because it will increase the oxygen demand and heart will get maximum load. Again, role of transesophageal echocardiography is very vital. So what is the advantage of the transesophageal echocardiography? Because it is a new weapons for the anesthetists to handle the emergency crisis. The advantage of the transesophageal echocardiography is you can early detect the ongoing MI by regional wall motion abnormality. the assessment of the LV function is possible. You can also assess the other structure of the heart like valve, septum, aneurysm, or any other thing which you had missed in pre-operative periods. The post-grafting assessment of the ventricle is very important to see the success of the grafting and revascularization. The disadvantage of T is you have poor image during time of grafting. The contraindication is a esophageal stricture, difficult intubation, acid peptic disease, and patient have bleeding disorder or something else. You cannot use transesophageal echocardiography. Again, there is a debate between the central venous triple lumen catheter, 4 lumen, or pulmonary artery catheter. The most common indication of the PAC is post-MI complication like VSR, ventricular septal rupture, LV aneurysm, patient is having a post-MI MR, patient is CCF, congestive cardiac failure, that is emergency surgery, redo surgery, or coronary surgery associated with other pathology like valvular heart disease or any other septal defect or something else. In those kind of patients where the pulmonary pressure of assessment of the preload is important, in those patients you can put a pulmonary artery catheter. Of course, the patient with poor ejection fraction, definitely it is a line of treatment you have to locate with the PAC. Now there is also debate going on between PAC and echo. PAC you can keep throughout a ICU period of the patient for 3 to 4 days, but you cannot keep the transesophageal echocardiography. So you have to use both. Intraoperatively you can assess with the transesophageal, and postoperatively you can manage with PAC. That is very good in sick patient. The induction of anesthesia, it should be very safe and slow. The midazolam we are giving with a dose of 0.1 mg per kg, approximately 5 to 6 mg in adult patient. Fentanyl is 250 microgram in 50 to 60 kg adult. I am routinely talking about the average adult male or female, approximately 50 to 60 mg 60 kg. In vecuronium you can use 0.2 mg per kg. You can use propofol if patient is hypertensive, and also inhalation agent like isofuran or sevofurane. Both is very good, you can use, because but you have to be more careful with the isofuran for the coronary still. The sevofurane is little safe. The maintenance of anesthesia with the fentanyl, vecuronium, and inhalation anesthetic agent. The overall aim of our induction of anesthesia is to maintain the hemodynamic stability. Most important is the anticoagulation and reversal. We are using heparin 100 unit per kg as compared to pump surgery we are using 300 unit per kg. Our target ACT should be between 250 to 300. The protamine we are equally neutralized for the heparin is 1:1. So 1 milligram have protamine neutralize 100 unit of heparin. In endarterectomy patient we are giving 1:1 or little less amount of protamine, but our ACT target should be between 150 to 170 to prevent the blockage at the site of endarterectomy. There are some intraoperative events how we can manage. Most common is a hypotension. That may be a normovolemic hypotension or that may be hypovolemic hypotension. If it is there, you have to check for the CVP. You can give fluids, maintain your heart rate. You can use vasopressor like noradrenaline. If any mechanical compression is there by the octopus, relieve it, and you go with the repositioning of the heart if during the grafting hypotension happen. If patient doesn't respond to inotrope fluid therapy and heart get distended, immediately go with the IBP insertion and manage the patient. Arrhythmia is another complication during any heart surgery. First, always you have to check for the electrolyte, and if there is a problem or there is a hypokalemia or something, just correct the potassium level. You can use lignocaine 1 to 2 mg per kg intravenously. Amiodarone is again a drug of choice to maintain the arrhythmia or restore the normal rhythm. You can use 150 to 300 mg followed by 2 mg per kg. That is the infusion dose. Of course, you can put a pacing wire and you can maintain the rhythm. And prevention of the reperfusion injury is very important, particularly in grafting of the right side of the heart. Prevention of myocardial infarction. How you prevent the myocardial ischemia intraoperatively? First, very important point is you have to maintain the mean arterial pressure between 60 to 70 millimeter of Hg, either by the fluids, either by the vasopressor or by the Trendelenburg position. always avoid the tachycardia, because tachycardia is never a physiological, it's always pathological. Of tachycardia causes increases the myocardial oxygen requirement and give rise to ischemia. Use beta blocker or calcium channel blocker to control the heart rate. There is a use of intraoperative coronary shunt. Once surgeon is putting a graft, they are using a shunt. How the shunt is helpful? It will maintain the native flow. It will provide a bloodless field. The smooth and safety in the anastomosis is possible with the shunt because surgeon can easily see the posterior margin of the vessels. The anterior margin is cut and the grafting is very easy and smooth. And because of the restoration of the native flow, you can prevent the ischemia. Now again we see what's the heart position and what are the hemodynamics. Mostly during the lifting and rotation of the heart, there is a compression effect of the octopus which can change the stroke volume, cardiac output, left ventricular and diastolic pressure and right atrial pressure. During LAD grafting, it is usually safe because of the anatomy of the left anterior descending artery. It may be critical if patient come with LMCA or chronic total occlusion. If you are not able to put a shunt in LAD, that may be because of calcification or endarterectomy. Sometimes LAD grafting gives trouble, but you can manage very easily. The most difficult and complicated part is the OM grafting or high ramus grafting, where there is a head low position and table is tilting on the right side. Because of that, there are high chances of PA compression and RVOT obstruction. The management is you can restrict the fluid if CVP is too high and give a support. You can use in high CVP, you can use NTG or you can use inodilator like dobutamine. But be careful, you should not give in high dose because it will give tachycardia and surgeon is not able to graft and there may be high chances of octopus may be dislodged from the heart. If fluid CVP is low, you can give fluid and you can use vasopressor also. Again safe technique is you can open the right pleura so that heart is getting a space to expand or accommodate the fluid in the right atrium as well as in the PA. Third one is the RC or PDA grafting. These are the routine grafting most of the institute is doing, and in this grafting there is a verticalization of the heart, that is a position, and head low is there. So in head low position you may misguide with the CVP. So don't be panic if patient gets high CVP. Just check whether patient is with the head low position or any twisting of the heart. Most of the time the surgeon is taking a post pericardial stitch to lift the heart for the RCA or PDA grafting. The most common complication during this grafting is bradycardia and hypotension that you can prevent with the vasopressor, atropine or using a pacing wire. Post-operative care is very important. Post-operative you can maintain the analgesia with the local infiltration by the bupivacaine at the local site as well as on the drain side, because drain side is more important and it is the most common cause of the pain in post-operative period. The intraoperative intercostal block is again a very well-known technique. You can use it and you can make the patient pain-free. Thoracic epidural catheter, that is again a continuous analgesia throughout the operative period as well as post-operative period. But you must put it one day prior to the surgery because intraoperatively you are using heparin, and if at the time of induction or before the surgery if you put it, if hematoma is happen or something bleeding is happen or traumatic epidural insertion was done, there are high chances of hematoma and cord compression which will give rise a serious complication in post-operative period. So be a safer side, always put epidural catheter one day prior to the surgery. IV analgesia is nicely available like paracetamol, tramadol or fentanyl infusion, that is dose of 1 to 1.5 microgram per kg per hour. So these are the various techniques to make the patient pain free as well as possible to go for early extubation. This is very important. What is a post-operative ventilatory strategy? You have to prevent the lima stretching by adjustment of the tidal volume and PEEP if patient is come with a COPD or some borderline respiratory problem patients. Fast track extubation possible if patient is hemodynamically stable and the drain is minimum. CNS examination is must. Patient should be fully conscious, awake, oriented, and patient is very much aware about the surroundings. Check the ABG, it should be normal, there should not be acidosis, there should not be CO2 retention, there should not be a base deficit. Check for the hemoglobin to check whether patient is not draining much. Sometimes you may not find anything in the drain, and patient has having a drain inside the chest, and your hemoglobin is persistently low. So you must be secure there is no drain inside as well as outside also. Normothermia is very important because in intraoperative period patient is totally exposed for the coronary, thorax is open, limbs are open for the conduit, and because of that there are high chances of hypothermia, and the hypothermia itself causing delaying the metabolism of some of the anesthetic agent. So normothermia is very important for the fast track extubation, and of course urine output, if it's adequate, you have to plan for the early extubation. It's very challenging nowadays because young generation is coming for the CABG, and the lifespan of the CABG is 15 to 20 years, and patient may come for the reduced surgery in later on. If such kind of cases are there in future, anesthetist and surgeon both has to on toes for handling such kind of situation. So what is needed? It's need expertise and senior hands. You must be experienced for the reduced surgery. You can use external defibrillator pad to prevent the to manage the any kind of arrhythmia or VTVF at the time of dissection for the reduced surgery. You can use radial arterial line, femoral arterial line, PA catheter, continuous cardiac output catheter, and TE according to your institute availability. So these are the little bit of more challenging for the anesthetist, and you must have good monitoring system available. Invasive cannulation according to the conduit selection for the graft, because patient is coming for the second time, you may have very limited resource for the arterial cannulation as well as venous cannulation. So just have good coordination between the surgeon and anesthetist, and you plan out for the any invasive cannulation. You must prepare the groin for the femoral bypass in case of emergency crash, because you never know, during sternotomy there are high chances of myocardial injury, some rupture, some tears, or some arrhythmia, or some defibrillation. In those kind of cases you immediately have to go on femoral bypass. That is only option, and you have to be prepared for that. The pump should be ready in any redo surgery. There are high chances to convert it into the empty beating heart because of the adhesion. Because of the previous surgery, you may not get a good expose to put new grafts. So you have to be ready with the empty beating. You must need a good amount of transfusion, blood products, and there are high chances of blood also because it's the redo surgery, and for that you have to prepare with the transfusion related injury. So how you can minimize the blood? You can use that's a cell saver, and because of that you can reduce the chances of blood transfusion and all. The post-operative patient may need long ventilation because of the long time of surgery, the grafting, as well as some of the complications. So for that you cannot go with the fast track, what you go with the routine CABG. You have to be on slow track, and you have to assess the patient thoroughly and plan for extubation. There is a key points and troubleshooting. What are the common problems you are facing in beating heart CABG? During sternotomy, there are high chances of bradycardia and hypotension due to vagal stimulation. So you have to be more careful. Use glycopyrrolate, atropine, or mephenteramine to maintain the blood pressure and the heart rate, and ask the surgeon to open the sternum gradually so that you can prevent the sternotomy induced vasovagal. The protamine reaction is more common. Mostly you have to use antihistaminic fluids and steroid, and be careful that protamine reaction is very dangerous. You are getting a high CVP or high PA with systemic hypotension. Sometimes you may get the flat line. So always give a protamine reaction with the negative test dose. The shifting hypotension is again a common problem if you are underfill the patient and you are not having a proper fluid management. So be careful for the proper fluid management and inotropic support to prevent this shifting hypotension. In severe hypertension with low ejection fraction, you have to optimize the inotrope. If patient is not responding to inotrope or you need high dose of inotrope, always think for the option of intra-aortic balloon pump. Patient with left main coronary artery and low ejection fraction, you must be ready with the additional femoral line, so that in any kind of complication intraoperatively as well as post-operatively, the insertion of IBP is very smooth and possible. TE is having a vital role in management of the heart in intraoperative period. and for the filling pressure or something, you can use PA line or cardiac output, continuous cardiac output monitoring. If patients come with a coronary artery disease with other pathology like valvular heart disease, any septal defect, in those kind of patients, you must take femoral arterial line, PA line, transesophageal echocardiography, and slow track extubation in post-operative period. Thank you very much. Thank you so much. Any question you can ask me.